Welcome to Goal Getter, the AAP Physiotherapy podcast. My name is Jen Pantelak, and I'm the CEO of the Alberta Association of Physiotherapy. This show explores the power of physiotherapy, helping individuals move, heal, and thrive. Let's get moving. With growing demand, long surgical wait times, and evolving models of care, orthopedics is changing quickly. Joining me today is Dr. Stephen Kwan, president of Alberta Orthopaedic Society and an orthopedic surgeon deeply involved in shaping how musculoskeletal care is delivered across the province. Dr. Kwan, welcome.
Thanks, Jen.
So, diving right in, from your perspective, how would you describe the current state of orthopedic care in Alberta?
Now, the status of orthopedic care varies basically from zone to zone, but in general, across the entire province, we're seeing like long waits for ORs. OR times are prolonged. We're having staffing shortages, especially nursing and anesthesia. And anesthesia is having a worldwide shortage, basically. We're basically poaching a lot of anesthesia care from other countries. Because of this, there has been prolonged waits for surgical care. Um, there are also prolonged wait times to see orthopedic surgeons. In general, it's basically over a year to see a surgeon and up to 2 to 3 years before surgical care is provided. There are overwhelming amounts of orthopedic trauma, and this has changed. The nature of trauma has changed over the course of the last 10 to 15 years. There has been a noted increase in periprosthetic fractures, which means that there's fractures about a total hip or a total knee. And this is more than likely secondary to the fact that we're doing way more total hips and total knees. Patients are living for prolonged times, and their medical needs have become way more complex. Also, the population has increased phenomenally, especially in Alberta, especially in southern Alberta and in Calgary. The resources that are needed for this population increase has not kept up. And this is shown in family practice, emergency medicine, hospital beds, hospitals, ORs, and other resources. In specific zones, what we're looking at is that there's a loss of first tier clinical support, or that means that the the care that's provided for patients that have had to be admitted to hospital has decreased or basically disappeared. This care has been provided for by surgical residents or residents that have been coming through the service, clinical assists, or what they're called physician assists currently, or hospitalists. The problem with residents is that it's not sustainable. The rural college has recalled a bunch of residents back from clinical sites due to teaching. Um, the clinical assist and physician assist program is not a sustainable system, and the hospital system is not sustainable. Plus, they're facing funding challenges. Um, this is occurring at multiple sites, especially at the main centers, and especially in Edmonton at the OSG or the Orthopedic Surgical Center at the Royal Alec. This is going to spread through the entire province. Four major and minor centers that are totally reliant on these first-tier clinical supports. This is resulting in cancellation of a lot of surgery, and especially surgery for those that are medically challenged. Um, if you're healthy and you're young, then you'll be picked up by the chartered surgical facilities, which we'll talk about in later in the podcasts. So if you're healthy, you get treated. If you're not healthy, you're going to be prolonged waited, and that's basically the downside of orthopedics in the province currently.
So, lots of a variety of challenges kind of contributing to, I don't know, I guess a bit of like the chaos that you're seeing across the
Wow.
province. So you mentioned in terms of like some of the bigger pressures, a lot of it has to do with human resources. We just don't have enough people to deliver the care that's required as we see the population like continuing to expand and especially to your point in southern Alberta. Would you say there's
Yeah,
anything else like contributing a lot to the pressures in terms of a patient access type of standpoint? Obviously, not having enough individuals involved to deliver the care is huge. Um, do you find across the province, like the rural versus urban, is contributing at all to that as well?
their prolonged waits are across the province, rural as well as urban. Um, the problem with the OSG in Edmonton has been well documented, and they were in the thousands of patients that were on their wait list. They're slowly starting, but they're a long way from catching up. In southern Alberta, it's like the wait for a total joint replacement is huge right now. It's so big that it's basically close to 2 years before, from the time that you see a surgeon, the time you sign your consent, to the time you get your surgery. The other problem with that is that a lot of surgeons, because they're prolonging waits now, are restricting or not seeing any new patients until they catch up.
Right. So we're going to dive into a little bit more some potential opportunities in the system, but maybe first let's talk a little bit about you mentioned the increase in total joint replacement.
Mhm.
So that's changed significantly. What are some of the important shifts that you've maybe seen in this?
We can go back a long time, um, because I've been at this for 30 years. I came through a system where total joint replacements, they were admitted for 2 to 3 weeks. We had a step down unit. Uh, the total joints took 2 to 3 hours to do. Now the total joints are being, they're taking 45 minutes to an hour to do. They're discharged either as same day of surgery or overnight stay, and you go home the next day. The only ones that are staying for only prolonged periods of time are those with complex medical needs. The major change has been the development of the hip and knee pathways, and that was a major project of the previous Alberta Bone and Joint Health Institute. That's now changed to the Institute of Health Improvement, the IIHO. But it developed out of a group of orthopedic surgeons in Calgary who felt that total joint surgery could be streamlined and could be made better. So this became it was adopted province wide and adopted in several places across the nation. So basically, what it involves, it's called a hip and knee clinic, and originally it did not involve screening for patients, but their main mandate was to optimize patients preoperatively as well as postoperatively. What the system ended up doing was there was optimization of the patient's pre-op, which meant arrangement of um, tests as well as X-rays and consultations, taking these responsibilities away from AHS facilities as well as the surgeon's offices, and also made sure that all these tests were done to appropriate patients, and none of the tests were missed, and thus cancellation at the time of surgery was markedly decreased. Um, the patients were set up preoperatively in terms of physiotherapy. They were taught how to use their aids of daily living, use of canes, crutches, teaching of stairs. They're also given equipment requisitions as needed, such as raised toilet seats, bed rails. Um, and then they had case managers that followed patients through their surgical journey. And these case managers basically followed them with a phone call 24 hours after the surgery, 2 week visit for a wound check, 6 week visit if necessary, 3 month visit, as well as 1 year visit. And then they were discharged after that. So what we found was that with this method, the patients were much happier. They were way more set up for their surgical journey, as well as rebounding back to emerge for pain, or pain management was markedly decreased.
And I feel like it's a lot of that patient education, which
Oh, it's
sometimes, right,
huge.
if it happens before, it's so much better than afterwards if they're in pain or maybe they're a little bit groggy from the procedure itself. So,
Yep.
from an orthopedic surgeon's perspective, you touched on a little bit about benefits for the patient themselves and having all this pre-op, pre-surgical optimization. From your perspective, why does what happened before surgery matter just as much as that surgery itself?
Well, previously, I didn't like. It was basically like I'd say the patient, you're getting a total joint replacement, operate on them, and then the physiotherapist and if necessary, occupational therapist would be talking to them after the surgery and getting all their equipment done. Now we're getting all the equipment done preoperatively, the teaching done preoperatively, so they can manage at home after the surgery. Plus, with the case managers, if they run out of pain medications, then they don't have to go back to their family doctor's offices. They don't have to go to Emerge. They can phone their case manager and get their prescriptions renewed um, by contact through the surgeon.
And from a physiotherapy perspective, what do you think the greatest impact that a physiotherapist can have along that joint replacement pathway is?
Right now, physiotherapy is not really involved in the pathway just because the physiotherapists have set up the pathway so well. The patients are given a booklet of instructions as well as a set of exercises prior to prior to their surgery to be done afterwards. The physiotherapist is involved directly post-op to ensure that the patients can get up, they're safe before they go home. And then if we're running into problems with range of motion, mobility, stability, then they get sent to physiotherapy afterwards, usually at about the 6 week to 3 month mark. Physiotherapy is extremely valuable in other joint surgeries and extremely necessary because of the range of motion or different type of surgery, especially for total shoulder surgery, rotator cuff repair, as well as knee surgery, knee ligament reconstruction per se.
Okay, so very customized depending on what it is that you might be having
Mhm.
surgery on. So you had mentioned the pathways created by the previous Alberta Bone and Joint Institute, and we're starting to see more of those clinics and rapid access pathways across Alberta. Do you
Right.
want to maybe speak to a little bit about the problem that these models are designed to solve?
Yeah, rapid access clinic is actually a extremely how should I put it? That's extremely interesting. So the history behind it basically started in Calgary and Edmonton. The Glen Sather Sports Medicine Clinic, which unfortunately is now shut, secondary to funding problems. The University of Calgary Sports Medicine Center, which is basically the flagship in terms of knee injury clinics, as well as the Southern Alberta Acute Knee Injury Clinic. They was modeled after the Calgary Clinic, but what they started with was that these people identified a necessary need in the community for knee injury, so that what they developed with this knee intake clinic, where patients were seen quickly and then assessed as to whether or not they're surgical or not. My experiences with them are actually quite um, involved, and because I ran a sports medicine or a knee injury um, practice, what I found was that prior to the implementation of these knee injury clinics and specialized care clinics, was that it would take 10 to 15 referrals before I would book one surgical referral. That meant that, and the patients would be waiting over a year to see me, so that a lot of these patients would be non-surgical, and those ones that are surgical had to wait a huge amount of time to be seen. After the implementation of these clinics, 9 out of 10 of these referrals now are surgical candidates because of the clinics had um, sorted out those that needed surgery and those that didn't. Those that didn't were then sent for physiotherapy or other appropriate treatments. And then if they failed or they needed further management, then they'd come back to the clinic and then be sent for surgical follow up.
So in terms of that patient experience, it was providing getting patients on that right path a lot sooner. So either yes, you're on the surgical pathway or nope, you don't need to wait to see a surgeon. Let's figure out what that best care pathway is for your condition and get you back and moving.
Yeah. Also, the prior to these clinics, what I was seeing was ACL injuries that were they were prolonged. They were anywhere from 3 to 5 to even 10 years out after their injury. But following the implementation of these clinics, you'd still see the occasional one, but realistically, I'm seeing now ACL injuries within 3 months of their injury. And the studies do show that if you can get to their reconstructions within a year of their injury, their results are much better.
So then one of the I mean, I think fantastic outcomes of these clinics would be that patients are getting care in a more timely manner and likely healing better than they previously would have having to wait.
Yeah, and then return to function, return to work, return to their activities of daily living and their sporting activities way faster.
That's so fantastic, like, being able to get people the right care in a more timely manner when we're seeing these huge waits in Alberta. From your point of view, what makes the clinics work so well? And then on the flip side of that, do you still find there's a little bit of growing pains with the implementation of these clinics?
Yeah, the rack clinics now have been spread out. There's 17 rack clinics across the province, and they're not just dealing with soft tissue knee injury now. What they're seeing in terms of screening is hip and knee osteoarthritis, acute knee, which is what we're talking about, shoulder injury as well as spine now. So what the ideal is to have the referrals sent from their primary care providers, or in the knee injury clinic case, they can be self-referred and to be seen within 6 weeks of their referral. Unfortunately, because of the backlog prior to implementation of a lot of these clinics, there's still a huge backlog to be seen by the intake clinics. Plus, now the because it's been so efficient, the it's not the wait list to be seen and sorted now, it's the wait list afterwards. So there's a huge amount of backlog to see the surgical referral afterwards now.
It's just pushing it along a little bit.
Mhm.
And part of it is that, again, go back to capacity?
It goes back to capacity, but I mean, a lot of these patients now are actually good candidates for surgery. But the what we're seeing is that the referral rate for surgical consultation from the RAC clinic ranges anywhere from 20 to 90%, depending on which clinic we're talking about.
Right. Once your point, you're actually seeing the surgical candidates that require surgery versus, to your point earlier, you would see a lot of patients and many of them maybe weren't a good surgical fit and should have been on a different pathway.
Right. Now that that's all sorted out, and that makes it a lot better.
If for some reason it didn't get renewed, do you think that some of the rat clinics would continue to operate in the way that they are?
It would be exceedingly hard. I mean, the only one that has ongoing funding is the Calgary Sports Medicine Center. The spine intake clinic at in Calgary basically is ongoing because of because of a different funding model that they've developed. They can continue, but the other RAC clinics, such as Sakic in Southern Alberta, the all the other RAC clinics are totally dependent on the RAC case rate funding currently to sustain operations. So if the funding disappeared, these clinics would more than likely not continue.
Which is so unfortunate because there's been so much success demonstrated and the access to care piece in terms of alleviating some of those system pressures has really been proven through the rat clinic
Mhm.
model.
Right. Yeah. Exactly. Yeah.
Are there any areas that a rat clinic hasn't yet been introduced into that could really help in Alberta?
Yeah. There's only, as far as I know, there's only one spine clinic, but there are two or three other spine intake clinics that are not involved in the RAC. This RAC system right now is a pilot program that's supposed to run till the end of March of this year. Then hopefully they'll figure out more funding for it and continue the program. But spine is one, foot and ankle is another, hand, wrist, and elbow is another, or other body parts that are not addressed by this RAC model.
Could there be opportunity in the future when the funding continues?
Oh, absolutely. Yeah. 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 There's been an attempt at a foot and ankle intake clinic, but that has not, that didn't bear fruit, so to speak.
And why do you think it wasn't successful like the others?
Foot and ankle is a very different animal versus shoulder and knee. So it was like it just didn't have the uptake.
So, putting my physiotherapy hat on, and maybe just diving in a little bit into the role that physio plays in orthopedic care, s- I assume that you often, like a physiotherapist, might be that first point of contact for a patient who has an issue and they're trying to figure out what the heck's going on. Um, how do you think that having a physiotherapist as the first point of contact may influence patient flow and then the outcomes as they enter into the system?
Let's go back a little bit. I'm gonna address that one as well. The rack clinics, the assessors in the rack clinics are in the perfect rack model, are physician assessors or physician extenders, and they're not physicians per se. The rack clinics themselves, they're using as assessors, as their primary care of contact for the patient, primary care sports medicine, physiotherapy, as well as athletic therapy. The ideal model is to have the physiotherapist as the first point of contact and some designated athletic therapists. So physiotherapy is huge right now in the rack model. So what they do is they see the patient, they assess the patient, and then decide whether or not they're surgical, non-surgical. They're also given a set of exercises, one physiotherapy visit with their rack visit. Their patient satisfaction is as good with the physician extenders as with the physicians themselves. So their satisfaction rate is exceedingly high, more than likely just because the physiotherapists and the athletic therapists are spending way more time with the patients.
Do you think having, whether it's the athletic therapist or whether it's the physiotherapist, doing that assessment, do you think that's contributed to the majority of candidates going on being surgical versus traditionally, to your point, you had to see 10 or 15 before you actually
No,
had a surgical candidate?
it's actually been very good. I mean, the patients coming out of these clinics, um, the surgical booking rate instead of being 1 in 10 is about 9 out of 10 or 8 out of 10 now, and that's been consistent even with the new model with the physiotherapist and the patient assessor or the athletic therapist being assessors. They're exceedingly good. The training programs for the assessors are done at each clinic. There's not a unified provincial or national standard that they have to achieve, and it's done within in house. So my experience with our assessors has been extremely good. They're highly trained to the body part which they're assessing. They're exceedingly capable, and it's not a knock against family doctors, but they're specialized in this body part, whereas family doctors have to know a little bit about everything or a lot about everything, and they can't specialize in say knee injury or shoulder injury. I mean, it is a major or a large part of their practice, but they don't see enough of this stuff to be really good at it. Where a assessor physiotherapist in the intake clinic may see 10 ACLs in the span of 1 month, where a family doctor may see one in a couple of years.
Right, and they also, I guess, from the physiotherapist perspective, have a little bit more time to spend assessing that individual patient versus if you go into a family physician, your time is a little bit more concise when you're
Yeah.
in those facilities.
Plus the the exam techniques are if you've honed them, you're exceedingly good at it. If you only use them once every couple of months, you're not going to be as good. So
For sure. Do you think, to your point, so every rack site has a little bit different assessment model, the training is a little bit different. Do you think that we could benefit in Alberta from having standardized assessment techniques or standardized assessment training for those stepping into the role?
yeah, I'd like to see it. It would be amazing if the say the rack clinics for hip and knee or the screening for hip and knee was uniform across the province, and that the assessors would be trained in the same method. However, given the success rate currently, there is no appetite to have a unified or a universal training program for this.
Are there any ways, like in the current system when it comes to racks or any of the other clinical pathways, where you feel physiotherapy is maybe underutilized or we could be leveraging it more effectively?
Yeah, the in terms of assessors, that's where the key is, as well as the non-surgical treatment model for them. They get one visit post if it's deemed conservative management, but certainly we can, if the case rate warranted, more visits. and more visits with a physiotherapy.
From your experience, so they're deemed non-surgical, they get one visit with a physiotherapist, and then really it's on that patient to decide if they're gonna invest in further care in the current
Mhm.
model, correct?
Right. Or they get sent to the GLAD program if they're osteoarthritis, hip and knee, smoking cessation um, programs, Alberta Aids to Daily Living for dietary management as well as injection. So they can be referred on to all these other programs that may help their joint.
Okay. So great to know that there's, like, other options out there, and maybe for those of us listening who don't know, could you explain a little bit more about the GLAD program or some of these group programs that exist in Alberta?
Yeah, it's a group exercise program for osteoarthritis, hip and knee, and it's been developed. I believe it's from Scandinavia, and they do a exercise program that may help the mild to moderate osteoarthritis patients regain some of their lifestyle.
From, like, as an orthopedic surgeon and from your perspective, people are living longer, you're seeing more complex cases. From a preventative lens, is there anything that the general population should be thinking about for some of those joints that we see bigger issues with down the road?
Yeah, the key messaging for prevention is movement, movement, movement. Keeping the weight down, moving the joint, moving the body, walking, swimming, cycling are super good for osteoarthritis, hip and knee. As well as using hiking poles, which basically give you a double workout. It gives you a lower body workout as well as an upper body workout. So it's like realistically, I can't emphasize enough the use of the body parts. Also, swimming, getting into the water and using the joint.
And swimming's so great because it provides you a lot of freedom if you are having aches or pains and you have that effect of not having the gravity pull against you as well.
Hmm.
So if we fast forward 5 or 10 years, thinking about the programs currently in place or the opportunities that exist, what do you hope orthopedic care in Alberta will look like?
Oh boy, that's a rig question. Basically adequate resources for all that we do. Adequately funded resources for elective surgery as well as trauma, so that we're not seeing fractured hips that are waiting 2 to 3 days or even 4 or 5 days to get care done. Fractures that are waiting up to 2 weeks before they're fixed. Ideally, fractured hips should be done within 24 hours. Other fractures should be done within 2 or 3 days. Compound fractures, stuff sticking through skin, shouldn't have to wait. They should be managed properly. Um, it's basically better and more efficient use of our existing system. Um, Judicious use of the certified or chartered surgical facilities, which means that they're the privately run surgical facilities, as well as equitable utilization of these sites in terms of utilizing the those that are working in both the public as well as private systems, so that it is not we're not robbing one system for another system. There should be stable funding for the hip and knee intake clinics or the hip and knee clinics themselves, as well as stable funding for the rack clinics. And I can't emphasize enough the the effect that the rack clinics have had on early orthopedic care and weeding out and managing patients. And in terms of systems, okay, sorry.
No,
In
no, no, but let's
that
talk about
part.
that, like, systems, like, how I feel like right now we're in a state of change in Alberta with healthcare rapidly evolving and rapidly changing. Um, I would love to hear from your perspective, like, what would make the system work better?
Well, there's been a huge amount of change in the methodology of how we do and what we do things too. Um, there's a lot of changes in approaches, methods of treatment, surgical techniques, surgical equipment. Um, Specifically, we were looking at direct anterior approach to the hip. That has made a big difference in terms of their length of stay in hospital. It makes a difference in early management, and they're moving way faster early. However, if you look at anterior versus lateral versus posterior approach. If they're well done surgeries, there's no difference at about 6 months, but the early management is hugely different. Robotics has been a huge issue right now in the States, which is coming. There's no robotics in the major centers in Alberta. I think there's one center that's using robotics currently. It's very popular currently for total knee surgery. There is robots for hip surgery as well as shoulder surgery. Um, they're in evolution. There's been huge discussion across the province as to who, where, and when it's going to come. But that for sure is coming. Whether it will make a big difference, we don't know. The early data says that once again, a well done total knee replacement versus a robot is not different at about the 1 year mark. Um, the private surgery question is a loaded question. Right now, there's a huge amount of um, angst going on in the province about how the chartered surgical facilities were procured, and that's being straightened out by investigations as well as with the government. Um, Currently, it is a publicly funded but privately run facilities, so that the Alberta government is financing these facilities, and that the surgeons are paid via Alberta Health rates. The surgeons that are working these facilities can work these facilities, but cannot work both the public as well as private facilities currently.
Okay.
If you want to work totally privately, then you have to opt out of the public system totally. I know that there's a couple surgeons currently that are just working the private system, and they opted out totally of Alberta Health Services. In Quebec, you can switch back and forth. You can have weeks where you're working private and then weeks where you're working public, and you have to let the Quebec Health Services know which one you're working, but you can't work both at the same time. You can get your surgery done privately, but you can only do this out of province.
Interesting. Are there any other jurisdictions in Canada that are currently like looking at this private public model in addition to Alberta that you're aware of?
Well, it's not we're working the public-private model currently, but you can't work both sides of the
Right.
system. Both sides, basically, real. You can't work both sides of the street, so to say.
Yeah.
They're looking at some legislation that will allow surgeons to work both sides of the street at the same time, but that is not passed yet. So the
What
issues with the private versus public system is that realistically, the people who work the public as well as private systems are from the same pool. So that means the surgeons work both sides: the anesthesia, nursing, and ancillary staff. So it basically can drain one service for another unless it's well managed.
absolutely. Yeah, absolutely. In terms of the patient experience, um, do you think that is going to change if legislation changes to allow surgeons to work both public and private? Or do you think it'll still be if you can pay privately, you can take that road, or else you're waiting in the public system?
Yeah, it realistically allows patients to pay for their own surgery and not have to go out of province if they want to pay. And if they find that the public system is a prolonged wait and they can't wait and they have the means to do it.
Outside of like you were talking about the robotics for surgery and how
Mhm.
that trend is coming, are there any other innovations that you're seeing, even like in other places around the globe that you're excited about that, maybe could benefit if it ever came to Alberta?
In a short answer, we're actually very good in Alberta, but there are a lot of advances that I can't think of one single advance that I would talk to. But from a lot of from my sports medicine colleagues, they're saying that a lot of the soft tissue knee surgery that's been done in Europe is very different than what how our approach is here in North America. I don't know exactly what they are, but um, because I haven't been to that meeting. I'd love to go and see what they're talking about.
Well, that's good to hear though that we do things really well in Alberta when it comes to orthopedic surgery.
Yep. Trauma care is exceedingly good. Um, yeah, we're becoming. It used to be that there we used to be a lot of very general orthopedic surgeons, and I'm probably the last of the one of the last general orthopedic surgeons that does total joints, sports, um, trauma, uh, and that kind of thing. And we're all becoming very subspecialized. Like some of the guys in Alberta now have never approached an open shoulder. They've all only done arthroscopic shoulder work. Some people have never done in their practice a total shoulder replacement, um, and others have never done a anterior approach to the hip. So it's becoming we're becoming very very subspecialized.
And do you think that's a like positive or negative for the system?
Well, it's very positive for the patient. I mean, it's like patients are getting basically subspecialty care. I mean, even in Lethbridge,
Yeah.
we have like subspecialty care going on currently. Like, there's a couple of people. Three of us are doing anterior approach to the hip. The other two are not. Um, there's a huge revision. There's a huge revision practice here. There's a shoulder arthroplasty program here. Three of us do shoulder arthroplasty in Lethbridge, as well as not just shoulder arthroplasty, but revision shoulder arthroplasty and complex shoulder reconstruction. So it is very different than when I started. And when I started, we had five people that just did general orthopedics. Um, now I did shoulder arthroplasty, but that was about it. I was the only one.
Right. So now when you go in for surgery, you know the surgeon that you're seeing with the specialization has, this isn't the first time they're seeing it in maybe a year or a few months because this is what they
No,
do day in and day out, and so
yeah,
they're, very specialized and, quote, unquote, "experts" in this specific area of surgery.
yeah, yeah. And now it's like now instead of like tackling a case that I would have tackled years and years ago, I have partners that are more qualified and have subspecialty training in the in this problem that would tackle it better than having me do it.
That's great. It's nice to see the evolution of care in Alberta and great to know that, we do have excellent care. I think we are well aware of that. Sometimes it just seems a little messy when you're waiting for a while to get the care that you need, but when you finally do get it, it's top quality.
Yep, yep. I would say it's very good care.
Oh, fantastic. Well, thank you so much. I've really enjoyed our conversation today. Not just talking about orthopedics, but talking about the system as a whole, and also like looking at that collaboration across professions and why that's so important as well in patient care. So thank you so much.
Well, thank you.
We just had a great conversation with Dr. Kwan about the state of orthopedic care in Alberta. If you're interested in learning more about physiotherapy or to find a physiotherapist near you, visit albertaphysio.com. See you next time.